Bismillahirrahmanirrahim. To start off the proceedings of this masterclass, first the topic is head injury, and we will start off with the pathophysiology, the types of head injury, and then we will determine how to determine the clinical, how to do the clinical and radiological assessment of in a patient with head injury. Next. So I'm Dr. Ali Tassadaq, Senior Registrar, Department of Neurosurgery, Shifa International Hospital. So we start off with the scalp. The scalp is there, and then there is a bone, the cranium, and then we have the dura mater. The dura mater is having two layers: the periosteal layer and the meningeal layer. Then we have the subdural space, and then the arachnoid membrane and the pia mater, and then we have got the brain parenchyma. So all these layers are protecting the brain. So how we classify the head injury? So we can classify head injury in different ways. So if we start off with by mechanism, so there may be a closed head injury or a penetrating head injury. So if there is a closed head injury, we can have a high velocity injury or a low velocity injury. The high velocity from automobile accidents and low velocity from falls or direct blow, that is assault. And if there is a penetrating injury, then we can have a gunshot wounds or other open injuries, such as injury from a knife or a dagger. So this is the CT scan of a patient with a penetrating head injury. There is a metallic object inside the brain that has penetrated into the skull and into the brain. That is most probably a shrapnel of a bullet. Due to all this pathophysiology that we have discussed, that the patient may have the contact or inertial injury, what are the consequences of the head injury? So maybe skull fractures, there may be a focal brain injury, or there may be a diffuse brain injury. So what happens at the cellular level? There are certain chemicals that are produced that can cause the ischemic, inflammatory, and neurocytotoxic cascades are activated, and they cause the neuronal, axonal, and astroglial damage, astrogliosis, neuroinflammation, and blood-brain barrier disruption that leads to altered protein synthesis and post-translational modification. So this is the mechanism of the primary injury. So what happens in the secondary injury is that we can prevent. So there is inappropriate glutamate release, and oxygen-free radicals are released, and there is anaerobic metabolism and ion concentration disturbance at the cellular level. That leads to cerebral metabolic rate of oxygen consumption is reduced, cerebral blood flow is reduced, hyperglycolysis leads to acidosis, and there is loss of autoregulation that leads to cerebral hyperemia and cerebral swelling. So coming from the pathophysiology, how we can clinically assess the patient. So we take a brief history of the patient, whenever we receive a patient of head injury. So we get to know about the mechanism of injury, the time of injury, there is any history of loss of consciousness, seizures, vomiting, any discharge from ENT or drug or alcohol history. Then we go for the examination. We do the primary survey, as we all know, and do the secondary surveys. So we do the C, A, B, C, D, E, and then in the general examination, we examine the scalp. We look for any scalp wound. We go for the CSF leak. We look for the raccoon eye that we see in this picture, and we look for the battle sign if there is a bruise on the mastoid area. Then facial fractures, and we do the craniocervical auscultation for any cervical disruption. Intracarotid disruption or facial palsy, look for any signs of depressed fracture. So cervical injury is always suspected in all severe head injury cases, and all the patients with severe head injury should have cervical spine stabilized. So what we do in the rapid trauma neurological examination, we look for the level of consciousness, we look for the pupils. So if there is any anisocoria, extremity movement, involuntary movements, any that may lead us to any seizures, response to pain, deep tendon reflexes and plantar response, and the brainstem reflexes. So how we assess the patient radiologically? We can do the skull X-ray. That is a very simple investigation that we can do at any area, but it has a very limited value because it just gives us information about the fractures. Then the CT scan, which is the mainstay of all the investigations, that is usually done at the first level. Then we can do the MRI, the fusion tensor imaging, and functional MRI. So what are the indications for CT scan? If there is a patient having a loss of consciousness, vomiting, seizures, basal skull fracture signs, post-traumatic amnesia, serious facial injury, multiple trauma, obvious depressed fracture, penetrating trauma, and suspected child abuse, all focal neurological findings. So we have to look for the blood, the hydrocephalus, cerebral swelling, skull fractures, infarction, pneumocephalus, and midline shift in CT scan. So how does the extradural hematoma looks like? The extradural hematoma looks like biconvex in shape. It is hyperdense, it is white structure. So it is limited by the corneal and the lambdoid suture and looks like a biconvex. So, so what happens is that there is a bleeding from the meningeal vessels or from venous sinuses or from the fractured bone. So in the subdural hematoma looks like a crescent shaped, and it is not limited by the suture lines, and it has usually the impact of trauma is more in cases of subdural hematoma, and the patient is also having brain contusions inside. So what happens the subarachnoid hemorrhage in the sulci of the brain, and it is due to the disruption of the pile vessels. So in the intracerebral hematoma, so what happens is that there is a blood inside the brain parenchyma, and if it is more than 5 millimeters, we call it intracerebral hematoma. If there is salt and pepper appearance and we have got a mixture of blood and brain, then we call it contusion. So that is the differentiating point between intracerebral hematoma and contusions. So diffuse axonal injury, it is due to the acceleration deceleration injury, and there is a microhemorrhages at the level where the brain has different densities. So usually at the gray matter white matter junction, and the most usual areas for the diffuse axonal injury microcontusions are frontal temporal white matter, corpus callosum, posterior limb of internal capsule, corona radiata, dorsolateral midbrain, and rostral pons. So MRI, T2 star or susceptibility weighted image sequence are the most important to identify the diffuse axonal injury. Thank you.